Thanks, Tiffany. And Claudine, what are your thoughts about this? And how does who would you decide to use this drug for? How do you think of, what do you think about adherence and the share of costs for patients?
So I think those are all critically important points, and I think we've raised already a number of the points that we think about with oral therapies versus IV and managing some of the pluses and minuses. One of the things that I don't think we've gotten to quite yet is just some of the issues in terms of compliance and adherence to therapy. We know that that's a big issue with adjuvant endocrine therapy, for instance, and it's not necessarily, it might be different when we're talking the metastatic setting in terms of adherence to therapy. There will be different factors pushing people one way or the other, but with complicated drug regimens, there is a lot of education, I think a lot of continuing education that needs to happen for patients, not only in terms of how they take the drugs and when they're supposed to take them, but also this question about managing toxicity and being very clear. I think one of the things that we have traditionally been very good at is if we're giving IV therapies, that the patients are coming into the infusion unit, they get a sort of toxicity check by virtue of showing up. And often the infusion nurses are often excellent at this. They call us, they page us, they have us come by. Different groups have different systems for it. But you lose that when somebody is on oral therapy. So I think it really underlines the importance of careful patient education, how to reach out, how to manage the toxicities and what to do about this. But obviously having more options is great. And these drugs, just because they're oral doesn't mean they don't have toxicity. So it's really balancing on an individual basis what's best for a particular patient.
Absolutely. And I think that's really well said. Priyanka, you mentioned that you're in a rural situation, and does this data, I mean, people did have nausea. So although the neuropathy was, to me, impressively better because, neuropathy is such a big issue for us in long-term paclitaxel, they did have nausea, but our colleagues in Central America said that it was pretty easily controlled with anti-emetic therapy.
So, for our patients, not needing to come to the infusion room every week would certainly be a plus. But the complexity of taking the medication would also have to be considered in terms of, you have to wait a certain number of hours after you take one aspect of it, and they take you multiple pills and then fast for more number of hours. And that would raise concerns with some patients where we don't know whether they would be able to comply with that complexity. One of the advantages of this particular oral formulation is lack of need for steroids. So a lot of patients are concerned about needing to take weekly steroids for weekly paclitaxel, especially those that have diabetes that's not well controlled. And we talked about potentially combining with other drugs. So lack of need of steroids would also make something like this more appealing to be able to combine with other drugs. Let's say, for example, PI3 kinase inhibitors or AKT inhibitors that cause hyperglycemia.
No, that's actually a really good point, the steroids. And also the point that you brought up about fasting is really important too, because interestingly, capecitabine doesn't have this, but this oral medication, as many have in the past, has very strict criteria in terms of fasting before and after taking the pill. And you do that 3 days in a row every week for 3 weeks out of every 4 weeks. So it's a big issue. They are studying whether or not they can have more food closer together and understanding the food effect. But that will be a big question for us in terms of how we are able to use this in different patient populations.